Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Late Relapses in Patients with Diffuse Large B-Cell Lymphoma Treated with Immunochemotherapy by Wang et al. My name is Ann LaCasce, and I'm an Associate Professor of Medicine at the Dana-Farber Cancer Institute in Boston, Massachusetts, USA. My oncologic specialty is lymphoma. The goal of upfront chemoimmunotherapy in patients with diffuse large B-cell lymphoma, referred to as DLBCL for the remainder of this podcast, is the permanent eradication of disease. In the era of rituximab, few studies with sufficient follow-up have examined the risk of late recurrence. An analysis of patients with DLBCL from the University of Iowa, Mayo, and validated in a separate cohort from the French study group of adult lymphoma demonstrated that patients who were alive and disease-free at 24 months from diagnosis had overall survival rates equivalent to the age and sex-matched general population. Despite this finding suggesting cure, late relapses are not uncommon. In the manuscript that accompanies this podcast, patients enrolled in the Molecular Epidemiology Resource of the University of Iowa/Mayo Clinic Lymphoma Specialized Program of Research Excellence with newly diagnosed DLBCL, as well as DLBCL with concurrent indolent lymphoma, were identified. 847 of the 1,324 patients treated with chemoimmunotherapy, with or without radiotherapy, between 2002 and 2015 were event-free at 24 months. These patients were subsequently analyzed for late relapse occurring after 24 months. The majority of patients, 87%, had DLBCL without evidence of coexisting indolent lymphoma. With a median follow-up of 62.9 months, 78 patients developed recurrent disease, and the cumulative incidence of late relapse was approximately 7% at 3 years, 9% at 5 years, and 10% at 8 years after achieving event-free survival at 24 months. Of the patients who developed recurrent lymphoma, 55 had DLBCL alone at baseline, and 23 had DLBCL with concurrent indolent lymphoma. Among the patients with DLBCL alone, 36 developed recurrent DLBCL, and 13 had indolent lymphoma, 12 with follicular lymphoma, and 1 with marginal zone lymphoma. 6 patients did not have pathologic confirmation of disease subtype at the time of recurrence. For the 59% of patients with cell of origin data determined using the Hans algorithm, rates of relapse in patients with DLBCL alone did not differ between those with germinal center-derived versus non-germinal center subtypes. Individuals with germinal center-derived DLBCL were more likely to relapse with indolent lymphoma. Of the 23 patients with concurrent indolent lymphoma at baseline, 9 relapsed with DLBCL and the remaining 11 relapsed with indolent lymphoma, 10 of whom had the same subtype at initial presentation, 7 with follicular lymphoma, 1 marginal zone lymphoma, 1 chronic lymphocytic leukemia, and 1 unspecified. One patient who had concurrent DLBCL and follicular lymphoma relapsed with mantle cell lymphoma, and the subtype was unknown in 3 others. Patients with concurrent indolent lymphoma at initial diagnosis were more likely to experience late relapse, which was driven by indolent recurrence. In multivariable analysis, concurrent indolent lymphoma and germinal center subtype were independent predictors of relapse. In patients with DLBCL alone, germinal center subtype was associated with indolent relapse but not DLBCL relapse. Advanced stage and higher IPI score were associated with higher risk of recurrent DLBCL but not indolent relapse. In terms of outcome, median overall survival after late recurrence was approximately 39 months overall, 30 months for those with DLBCL and not reached in patients with indolent lymphoma. This study emphasizes the importance of long-term follow-up of our patients with DLBCL. Hematologists-oncologists typically see patients frequently after the completion of initial therapy, but over time visits become less frequent or not at all for some patients who remain in remission beyond the 5-year mark. Multiple studies have examined surveillance strategies in this setting. The likelihood of identifying recurrent disease in an asymptomatic patient with a normal physical exam is extremely low. In addition, there is no clear evidence that surveillance imaging or early detection of an asymptomatic recurrence impacts on overall survival. This is particularly true for patients who relapse with indolent disease, some of whom may be followed expectantly. Others may be candidates for low-dose palliative radiation or reduced-intensity therapies. The National Comprehensive Cancer Network guidelines, which are widely used by physicians as well as payers to determine insurance coverage, recommends symptom-guided imaging in patients with a history of early-stage DLBCL and CT scans no more often than 6 months for up to 2 years after the completion of therapy in patients with advanced-stage disease. Imaging is associated with false positives as well as radiation exposure, and it is expensive for our healthcare system. In addition, anxiety associated with scans is common and may have negative impact on patients. Nonetheless, given that recurrences do occur, educating survivors and their physicians, including primary care providers, to be vigilant for the development of persistent symptoms without clear explanation, as well as B symptoms and lymphadenopathy is important. Setting expectations with patients is also essential, as is caution in using the term cure. Although the vast majority of patients who remain in remission beyond 2 years after the completion of initial therapy are likely to remain disease-free, a small minority will go on to develop recurrent aggressive or indolent lymphoma. In patients with germinal center subtype of DLBCL, discussion of the risk of subsequent development of an indolent lymphoma may be warranted. Future studies examining changes in cell-free DNA during and after therapy, as well as the development of other novel biomarkers, may eventually allow us to be more accurate in our prognostication for patients. In addition, understanding the biology of late recurrence to ascertain whether the recurrence represents the original clone or is distinct may ultimately be important for therapeutic approaches and outcome. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.